can get started. Thank you, everyone. Welcome, Dr. Elena Moore. Thank you so much for spending time with us this evening to inform us of some of the new updates to treatment in ovarian cancer. Without further ado, I'd like to welcome you. You could introduce yourself.
Good evening. Hi, everyone. Thank you so much for having me tonight. I'm very excited to be here and to talk about a very exciting advancement in our field, PARP inhibition, which I know many of you are probably familiar with, at least the concept of it, but tonight I'm looking forward to delving into a little bit more detail with you about it. My name's Elena Moore. I'm one of the gynecologic oncologists over at North Shore. And thanks a lot for attending my lecture. We'll kind of get started. I have several slides I want to share with you. So in the interest of time, the first thing we're going to do is talk a little bit of just review of the ovarian cancer treatment paradigm and where we've stood until now. We're going to talk about how PARP inhibitors work. What's the mechanism of action? Because that's always a common question. We will go into a bit of review about genetic testing because as we find from the literature, which we'll also review, the genetic testing is critical to finding out who are the best people for PARP inhibitor treatments. We're going to spend a good amount of time looking at some of the data for PARP inhibition in ovarian cancer and what are the indications for its use. I do want to go over side effects with you because that's also a very important consideration with treatment. And then we'll end on some kind of practical considerations that we've learned in our practice just now from using this drug for several years that hopefully will be of interest to you. So just a global view of ovarian cancer, and I know you are all familiar with these statistics, and I like to always highlight that these are just statistics. No individual person is a statistic, which is the best part of it. But ovarian cancer is a very serious cancer. It ranks 5th in cancer deaths death amongst women, and it's the most deadly of the gynecologic cancers. In 2020, we're anticipating about 21,000 new cases of ovarian cancer and about 14,000 deaths. So one thing that's been very bothersome in ovarian cancer treatment for a long time is that over the past 24 years, the death rate really hasn't improved by much. So we're really up until now, been using many of the same drugs and have not really been improving our survival rates. And so this really highlights the critical importance of us finding novel and effective treatments that we haven't used before. Unfortunately, because ovarian cancer is difficult to detect, most patients will be advanced stage disease once they're diagnosed. So most women will typically undergo primary treatment that will consist of surgery and then followed by chemotherapy. More recent data suggests that in some women, doing some amount of chemo before surgery actually to shrink things down, and then following that by a surgery and additional amount of chemo may be a better approach, and we call that neoadjuvant chemotherapy. So you see that here. The chemo that we use in ovarian cancer treatment in the front line is almost always a combination of some platinum agent like carboplatin and oftentimes Taxol. Those are usually our first line treatments. So after we finish chemotherapy, then we enter this surveillance phase, or that's kind of been our typical approach. And that consists of office visits, physical exams, pelvic exams, CA-125, tumor marker, which I know many of you are probably familiar with, and then imaging as indicated. In general, about 70 to 80% of women will achieve a remission after that frontline treatment. However, some patients will go on to recur. And subsequent treatments are typically defined by the length of response to the prior treatment, the prior platinum treatment. So you guys may have heard these terms before, but patients that recur within 6 months of completing their platinum chemotherapy are typically considered to be a term called platinum resistant, whereas people who recur within greater than 6 months are considered platinum sensitive. However, we're now kind of going into a new paradigm that's extremely exciting. So Instead of going directly after adjuvant chemotherapy into a surveillance phase, we're now looking at treating a select group of patients with a maintenance therapy. And that's an effort to try to prolong the interval between treatment courses. And so this is a lot of what we're going to be talking about today, is kind of this shift in paradigm of how we treat ovarian cancer. We're also now well within an era of what we call targeted medicine to try to better individualize cancer treatments. So instead of kind of lumping patients into these very broad groups like being platinum sensitive or platinum resistant, we're actually now using molecular profiling to try to identify biomarkers that can actually predict a patient's responsiveness to different classes of drugs. And so we're basically now individualizing treatments for cancer to the actual molecular biology of each patient's makeup. And this has been a very significant advancement in cancer therapy, not just ovarian cancer, but just in the field of oncology in general. So I hope this isn't getting too sciencey, but I figured if there's any group that's well informed and educated, it's you guys. You will appreciate it. But I do feel that in order to understand how PARP inhibitors work and really what they are, it's important to talk a little bit about DNA repair. So in general, you think of if a cell has DNA damage, it can lead to genetic instability and actually eventually to cell death. And in order to counter this, cells have developed pathways through which they can repair this DNA damage. And there's two main types of DNA kind of breaks that are listed here. So single strand DNA breaks are repaired using the PARP family of proteins through a process that's called base excision repair. Double-stranded DNA breaks are repaired mainly through a process called homologous recombination. And that involves many genes, but I've listed some of the most important ones here. And if you have any of faulty genes within this pathway, it can lead to this homologous recombination pathway breaking down. And you'll see in the upcoming slides, we're going to refer to homologous recombination pathway as just as HR for short. So it involves anyone who has any mutations within this group of genes here amongst some others. But of these, the most well-known and kind of most well-described are these BRCA genes, BRCA 1 and 2. But since those have been discovered, another longer list of genes within this pathway have also been found, and these all have very, very important clinical indications when we're talking about PARP inhibition and ovarian cancer treatment. So how does this all work? Well, in normal cells, you can see here, if there's DNA damage, it can cause these single-strand DNA breaks. And these breaks are repaired by PARP. And if PARP goes on to repair these breaks, and then the cell can kind of go on and have a normal survival. However, in this lower diagram here, you can see if the PARP proteins are malfunctioning or if they're being inhibited, so this little guy here is an inhibitor of PARP, then basically the cell's ability to repair these single strand breaks is lost. It can't repair single strand breaks anymore. And over time, what that actually leads to is double-stranded breaks. So the punchline here in this line is basically that if you inhibit PARP, it actually downstream can lead to double-stranded DNA breaks. So why is that important? Well, the main and most efficient pathway for the body to be able to repair these double-stranded DNA breaks is by that homologous recombination pathway we talked about. So you see all these genes kind of down this pathway listed here. BRCA 1 and 2 are two of the most important ones. And when a cell has a mutation in one of those genes, so in any of these homologous recombination genes, it's not able to repair these double-stranded breaks that are caused by the PARP inhibition, and then the cell goes on to die. So this is a very sneaky type of a concept that we call synthetic lethality. So in patients who have mutations in this homologous recombination pathway here, like BRCA 1 and 2, their cancer cells cannot repair the double strand breaks that the PARP inhibitors cause, and then they go on to die. We're basically capitalizing on the cell's inability to repair DNA to kill the cancer. And that's the basic bottom line of how PARP inhibitors work. So let's turn a little bit more to the clinical application of this homologous recombination pathway. As it turns out, alterations in many of these genes have been found to increase the risk of ovarian cancer. So BRCA gene alterations are the most famous and the most well described, and they increase the risk of ovarian cancer most profoundly, but the other genes will also increase the risk of ovarian cancer pretty significantly. You can see here in the general population, the lifetime risk of ovarian cancer is about 1.4%. So about 1 in 70 women have a chance of getting ovarian cancer if they have a baseline population risk. When you're talking about BRCA mutation carriers, that risk increases to about 20 to 40%, depending on which study you read. And the other homologous recombination deficiency genes also increase the risk, not as much as BRCA1 and 2, but still not insignificantly, at least 4 to 6-fold from baseline risk. Since mutation in most of these homologous recombination genes increase the risk of ovarian cancer, it's also not surprising that homologous recombination deficiencies, and when we say deficiencies, we mean mutation basically, are also quite common in these patients. So in fact, this is kind of newer data and it's pretty exciting. Up to 50% of women who have advanced ovarian cancer are going to have some mutation in the homologous recombination pathway in one way or another. Most commonly, it's going to be a BRCA mutation, but in up to 30% of patients, there actually will be what's called BRCA wild type, which means they are BRCA negative, but they'll have some other homologous recombination deficiency or mutation. And this is very important because based on the science of DNA repair that we just talked about, basically all of these patients on this whole half of the pie graph of all ovarian cancer patients are going to be more likely to respond to PARP inhibitors. So this is really big. And we're going to talk about the progression of how we got to this data. But for a long time, we thought that BRCA patients were really the only people who were going to respond. And now because of us finding out this data, that there's actually this other list of homologous recombination deficiency genes that also increase the likelihood of responding, we're able to really find a broader group of women that can benefit from PARP inhibitors. So I'd like to spend a few moments talking about the different types of genetic mutations, because this is also very pertinent to the PARP conversation, and it's a little bit confusing. But finding these mutations is basically what helps us to figure out who is going to respond better to a PARP inhibitor. So there's kind of two main types of genetic mutations that we talk a lot about in cancer treatments: germline mutations and somatic mutations. So what does this mean? Well, germline mutations are inherited from one or both parents, and they're present at the time of embryogenesis. So as the embryo is forming, those mutations are already there. Therefore, all of the cells within that baby or person are going to contain this mutation. So the entire organism, every cell in the body has it. And what's important about a germline mutation is that 50% of the offsprings of the person with the mutation are going to carry that mutation as well. So the offspring of people with these germline mutations have a 50% chance of also inheriting the mutation. On the other hand, somatic mutations occur at a later time. So they're actually after embryogenesis, and they're only present in the affected cell where the mutation started. And all of that cell's descendants. So typically for our purposes, what we're talking about is a mutation that's present only in the tumor. It's not present in all the cells in the body, it's just present in the tumor. The big difference is that those mutations are not inherited and are not passed down to the offspring of people who have those mutations. So germline mutations are found in every cell in a patient's body. Somatic mutations are found in the tumor itself. But the bottom line is that you need to do both germline testing, so that's done by checking a patient's blood typically, and somatic testing, and that's done by testing the tumor to obtain the best detection rates of mutations in this homologous recombination or HR pathway. So finding that you have a mutation in either of these, either the germline or in the tumor, suggests that you have a better response to PARP inhibition. And so we've really moved from where we always were testing for these germline mutations, that was always our recommended test for women who had ovarian cancer. We're now moving to this, what we call paired testing, where we're testing the patient and we're testing the tumor at the same time to try to maximize who's going to benefit from this. So how do we actually perform the genomic testing? Well, up until 2013, Myriad was the way to go. They held a patent on the BRCA genes, and so that was the only test that you could do. But there was a landmark decision in 2013, and Myriad was overturned, and they decided that you cannot patent a gene. And so now there is actually a host of different companies that can perform germline testing. They each have their own panels, so they test sometimes different mutations in specific genes, but for the most part, they all test those big genes that we talked about in the homologous recombination pathway. I do want to take a minute just quickly to discuss color genomics and then 23andMe. So these are both testing panels that offer direct to consumer testing, meaning you can just go online and order this test. You don't have to see a doctor. You don't need a doctor's orders. You order it on your own. So color genomics will actually do a full homologous recombination deficiency panel. 23andMe will test just for BRCA. One thing that's really important to know about 23andMe, and I don't think this is really common knowledge, and I've seen several patients who've been misinformed about this actually, they only test for 2 specific mutations in BRCA1 and 1 mutation in BRCA2 that are the founder mutations in the Ashkenazi Jewish population. So these represent the majority of mutations in Ashkenazi Jewish patients, but not necessarily in the general population. And it's super important for people to know that if you have a negative 23andMe test, it does not completely exclude the possibility that you could have a BRCA mutation. So they don't really advertise this well. And I've actually had several patients who have come to see me who were thinking that they were, when you'd ask them, they say, oh yeah, I'm BRCA negative. But when you kind of delve a little bit further into it, you find out that they had the 23andMe, so they're BRCA negative for those few founder mutations, but they haven't had the full BRCA testing. So just something important to know. And that's one of the things, as a caveat, just a shout out for our phenomenal medical genetics division that we have at North Shore, who do a phenomenal job of counseling patients. So one of the things I worry about the direct to consumer testing is that you just don't get the counseling up front that you would get if you see a genetic counselor. Not only, and a lot of people think, well, I just need the counseling if I have the mutation. It doesn't matter if I don't have it. But these are the types of counseling pieces that can be missed if you don't necessarily see somebody for the full genetic counseling. So I'm a big proponent of the geneticists. They are super smart and wonderful. Somatic testing panels are offered by many companies as well. So this is now moving to testing the actual tumor for mutations. Some have unique features. So Myriad was the first, again, they were kind of the first to the table. Their test is called My Choice, and that's actually the companion diagnostic of many of the trials we're going to discuss. So that was the test that many of the trials required to be done for patients to enter in the clinical trial. So that's kind of the gold standard. A couple other interesting ones. So Guardant 360 is actually a liquid biopsy. So they get blood sample and they obtain tumor information from the peripheral blood. Tempus is another one that is kind of more like a Googling. It Googles, it kind of a Google effect of testing and tests the paired tumor and the clinical information of the patient and kind of puts it together. But essentially, they all of these here accomplish the main goal that they look at genetic mutations within the tumor. So let's start moving on to actually talk about the PARP inhibitors themselves. These are the PARP inhibitors that are currently being studied. You can see here Olaparib, Rucaparib, and Niraparib are the biggest players that we talk about in the news. And I'm going to talk about them by their generic names mainly in this talk, but here are their brand names. Many of you may know them as Lynparza for Olaparib, Rubraca for Rucaparib, and Zejula for Niraparib. Olaparib is unfortunately still investigational. It doesn't have an FDA approval for any type of treatment at this point. And then Talazoparib is well studied, but it's a breast cancer treatment. It hasn't really been looked at for ovarian cancer too much yet. So before we delve into the clinical trials looking at the PARP inhibitors themselves, I think it's important to try to clarify one point, which many of you probably know, but I just want to clarify what's the difference between treatment and maintenance therapy, because you'll notice in the trials that we're going to talk about, they're used for very specific indications, and there's a difference between them. So a treatment is an initial treatment that's used, an initial treatment used in an attempt to shrink a current tumor. So that would be, for example, using carboplatin and Doxil for ovarian cancer that's recurred. That would be considered a treatment. A maintenance therapy is continuing to treat after completion of a standard round of chemo. And so it's used to basically try to avoid or slow cancer's return, or to slow the growth of an advanced cancer after the initial treatment. So maintenance therapy would be something that would be continued typically after chemotherapy treatment, but those are different terminologies. It's important because we're going to talk about some trials where PARP inhibitors are actually used for treatment, not maintenance. And that's why it kind of matters what terminology we're using here. So let's start talking about the actual indications to use PARP inhibitors for ovarian cancer. Well, the first FDA approval for PARP inhibitor was for Olaparib as a monotherapy, meaning treatment. So when we say monotherapy, we mean treatment. This means using just your cancer's back, not going on chemo, but going on Olaparib instead as its own treatment. This approval came from data from a study that was done by Kaufman and colleagues. So they looked at women who had platinum-resistant ovarian cancer, who'd had three or greater prior lines of therapy. And by therapy in that situation, that meant chemo. And in this group who received the Olaparib, there was actually a 31% response rate to the Olaparib alone without any chemo with it. So that's actually quite high for that particular cohort of patients. And this led to the FDA approving the drug for treatment in women with BRCA 1 and 2 mutations who had had 3 or more prior lines of treatment. And the approval came December 19th of 2014. So this was a really big deal because this was the first time that any agent in this class was ever used to treat ovarian cancer. And it actually had quite a good response rate. In fact, arguably as good or better than what chemotherapy would have in that same setting. But this was specifically in women with BRCA mutations. So next we're going to look at Olaparib as a maintenance drug. And the first publication from this trial came from a study that's called Study 19. And this was done in women who are platinum sensitive, who had completed at least 2 prior lines of treatment. And they were basically randomized to either get Olaparib or to get a placebo. Now, the very big difference in this trial is that both BRCA positive and BRCA negative patients were included in this trial. And the results showed a statistically significant improvement in progression-free survival, but no improvement in overall survival. So just a quick clarification, because we'll hear this term during the talk. In cancer trials, we use a term called progression-free survival, or PFS, a lot, and you're going to see that in the slides. So what this basically refers to is the time during and after treatment that a patient lives with disease that does not get worse. So for these trials, for how long after they started these medications, so like after they started Olaparib, how long did they live without the cancer growing or getting worse? And that would be considered a progression-free survival. And we basically use that as a surrogate for how well a treatment works. So you can see in this particular trial, the progression-free survival, or PFS, for the Olaparib group was a little better than the placebo, but it's not wildly so. You know, it was less than 4-month difference. And interestingly, based on the results of this trial, the drug company AstraZeneca was not impressed with that progression-free survival benefit, and they actually halted the development of Olaparib for a period of time. So they thought, you know what, I'm not sure that this is going to be worth our investment. We're probably not going to sell much of this. We may stop making it. Well, actually, in May of 2013, there was a reanalysis of the data from that trial looking at the BRCA positive patients. And you can see here actually that the progression-free survival was actually much more dramatic in that group. So now we're talking about a progression-free survival of 11 months in the Olaparib group versus 4.3 months in the placebo group. And here you can see this is the proportion of patients that were progression-free from Olaparib versus placebo. So a nice visual that the Olaparib patients did much better. And actually, interestingly, this led to AstraZeneca deciding to reinvest in the drug, thank goodness. it was a really big deal because it showed that maybe PARP inhibitors are actually a very effective class of drug, but maybe the big problem was that we were just not looking at the right population of patients. And this is actually something we think about a lot with oncology trials and clinical trials, is that you get the data from these trials and sometimes you can get negative studies if you're not looking at the right group. If you're not looking at who would benefit most from them and you're just lumping all comers together, you can actually end up throwing a drug out that could be very beneficial for some people just because you don't know who you should actually be using it in. And that actually almost happened with Olaparib. And thank goodness it didn't. So luckily this reanalysis showed that there is a group that it's much better for, and they were back on the bandwagon with the Olaparib. So that actually led to looking at Olaparib as a maintenance specifically for BRCA positive patients. And this is a group of trials called the SOLO trials. So SOLO 2 was a trial where they looked at women all who had BRCA mutations and recurrent ovarian cancer. And they had to have responded to the last platinum chemo that they got. And then they were randomized to get either maintenance with the Olaparib or a placebo. And so they basically took either Olaparib or placebo until they had progression of their disease, if that happened. So another little kind of clinical trial lesson. This is called the Kaplan-Meier curve here, and it shows basically a visual outcome of what happened to these patients. You'll see a few of these in this talk. So the horizontal axis here is time, and then the vertical axis is the proportion of patients that are surviving or progression-free. And you can see here, it's a little bit small, but the red curve is a Olaparib group and the blue curve is a placebo group. So you can see that the red Olaparib curve lived a lot longer without progressing than the blue placebo curve here. And in the trial, the progression-free survival for Olaparib was 19 months compared to 5 months for placebo. So it's a really big deal. And actually just this year, they presented the updated, it's not published yet, but it was presented at ASCO, our big meeting in the spring, the preliminary overall survival data, and it's very, very impressive. So 51 months for the people who got Olaparib versus 38 for those who did not. So it's obviously very, very effective, specifically in BRCA positive patients as a maintenance therapy and this is in the recurrent setting. So these trials that we just talked about together led to the FDA approving Olaparib as a maintenance therapy for recurrent ovarian cancer on August 17, 2017. And they actually approved it for both BRCA positive and BRCA negative patients, even though we can say that the results in the BRCA negative patients were definitely more modest. So what about Rucaparib? Well, Rucaparib was studied a little bit later. So this is the data for looking at Rucaparib again as a treatment, so monotherapy as it's on its own. And they looked at, it's called the Ariel 2 study, and they pooled the data from Ariel 2 with another study that's called Study 10. And it showed that the response rates to Rucaparib alone were actually very good. They had about an overall response rate of 54% with a pretty tolerable side effect profile. And this led to Rucaparib being approved as a monotherapy in patients who were treated with 2 or more prior lines of chemotherapy. And this is interesting. So this was the first time that they approved it, not only for people who had germline mutations in BRCA, but also somatic mutations in BRCA. So one difference that if we look back at our slides between Rucaparib and Olaparib as monotherapy, Olaparib, you had to have 3 prior lines of chemo. And for Rucaparib, that moved it up to 2 prior lines of chemo. And then for Rucaparib, now you can use it whether the mutation is in the blood or if it's in the tumor. So we're now basically, you can see, starting to expand our use of the ways we can use PARP inhibitors for treatment. So similarly to Olaparib, Rucaparib has also been approved as a maintenance therapy, and this is based on the Ariel 3 study. So similar to that SOLO 2 trial we talked about for Olaparib, Ariel 3 looked at women with recurrent ovarian cancer who had responded to platinum-containing chemo, and they were randomized, again, similarly to either Rucaparib or placebo. And this is another big difference. So now, unlike Solo 2, they included patients who were BRCA, but they also included patients who had a homologous recombination deficiency, so a mutation within that same pathway, but not the BRCA mutation. And they included people who had no mutations at all. And so this is where you can tell chronologically, we're now getting to the point where we're realizing, hey, BRCA is not the only mutation in this pathway that matters. In fact, there are other people that can benefit from this. So let's take a look at how those people do. And you can see that in this group that got the Rucaparib as a maintenance, they had an improvement in their progression-free survival in all of the cohorts. So for BRCA positive patients, it was 16 months versus 5 months. In patients who had a different homologous recombination deficiency, but not BRCA, they had 13-month progression-free survival versus 5 months for placebo. And then for all comers, where they lumped these groups plus those that did not have a mutation, it was 10 versus 5. So everybody had an improvement in outcome, but again, the patients with BRCA or homologous recombination deficiency did the best. And this led to the FDA approving Rucaparib for maintenance in the recurrent setting for all comers in 2018. So now, once again, we are widening our group that we can use these medications for. So niraparib was kind of last to the party in the PARP inhibitor world. The Quadra study looked at women who were quite heavily pretreated, so they'd had at least 3 prior lines of chemotherapy, and they received niraparib as a treatment, so as a monotherapy. And interestingly of note, in this particular study, most of these women were considered platinum resistant or refractory. And refractory means that their tumors actually grew on their last platinum chemotherapy. So that's actually a group that's in general much less likely to respond to any type of treatment. And still in that group, niraparib had good activity with a response rate of about 24%. So this led to niraparib being approved for any HRD positive ovarian cancer as a treatment for 3 or more prior lines of chemotherapy. So another drug that we can kind of use in our arsenal. So this is getting a little out of chronological order, but prior to this, the NOVA study, so before the monotherapy study was done, the maintenance study was done for niraparib. And this looked very similar to that other Ariel 3 study. So again, we're talking about recurrent ovarian cancer who had finished platinum chemotherapy, and they were randomized to either the niraparib or the placebo for a maintenance therapy. And similar to Ariel 3 that we just talked about, basically a significant response was seen in all of the groups. So again, we're now looking at all of these patients. So the germline BRCA patients had the best response. Those that had a homologous recombination C deficiency mutation of a different sort did well as well. And then those that had the homologous, had no mutation, basically did a little bit less well. But there was still benefit in all of the cohorts. So in 2017, March 2017, niraparib or Zejula was approved by the FDA as a maintenance therapy. So here's a little table study, just kind of summarizing what we just talked about for the maintenance trials. And basically the bottom line is that we did see responses even in women who had no mutations, but we can definitely say that in general, the most robust responses we're seeing in these maintenance trials are in women who have a BRCA mutation or who have one of the homologous recombination deficiencies. These are the cohorts that are going to benefit the most from a maintenance treatment with a PARP inhibitor. So now if we kind of revisit our treatment paradigm that we talked about, while traditionally in the recurrent setting, we would treat with chemotherapy again, and then we would go back to surveillance, basically from here back to surveillance, and then back to treatment, back to surveillance. We are now offering a maintenance. So instead of that, after recurrence, we're offering maintenance therapy, and that can increase the treatment-free interval, which is hugely exciting. I mean, we're very excited about it. But given now what we know about PARPs and the fact that they can increase the time to recurrence in the recurrent setting, this basically begged the question, well, if it works in a recurrent setting, what can we give it earlier? Is there any role for giving a PARP earlier in this kind of treatment paradigm? So what about the frontline setting? What happens if we give it up front? So what about those patients that had the surgery followed by chemo or surgery, or neoadjuvant chemo, surgery, chemo, and now usually those people would just go right into the surveillance phase. Well, is there any role for moving PARP inhibition use up to that point and using it after the primary treatment? And this first answer to this question came from a trial called SOLO-1. So this is very exciting. And you can see the dates in these trials. This is all new stuff. So this is like one of the most exciting thing that's come out in ovarian cancer in a super, super, super long time. In the SOLO-1 trial, there are about 400 patients that had BRCA mutations. Most of those are germline, but there were some somatic. And those women were randomized to either get 24 months of Olaparib maintenance after they finished their chemo or placebo. And just a few characteristics about these patients that we should point out. So most of those patients had stage 3 disease when they were diagnosed, which as we know is the most common stage, but there were some stage 4s. And 80% of those patients had had a complete response to their first frontline therapy. So basically what that means is when they finished their chemo after their first diagnosis, they had normal CA-125s, normal scans. So they were considered, quote unquote, kind of to be in remission. And 80% of patients were in that setting. Now, 20% of patients didn't have a complete response. They still actually had some measurable tumor when they finished their chemo. And even those patients did well with the maintenance. But overall, this is, I would say the important part of this is that this is just kind of real life. This is what we see for most of our patients, that most women are stage 3 when they're diagnosed and most patients have a complete response. So it's we care about that because it means that this data should be very applicable to our patients that we see and take care of. So at a follow-up of 41 months, the progression-free survival for the placebo group was 13.8 months. So their cancers came back on average in about 13.8 months. And when this was published in 2018 in the New England Journal, the median progression-free survival for the Olaparib group had not even been reached. So they didn't even have a PFS data point because they were doing so well. After 3 years, 60% of the PARP patients, the Olaparib patients, were still in remission, where only 27% of the placebo patients were in remission. So these are unprecedented results. These are huge, huge results for us in our field. And as you can imagine, not surprisingly, this led to the FDA approving Olaparib to be used for primary maintenance in the setting of treating ovarian cancer with a BRCA mutation. So Olaparib was the first to the party for primary maintenance, and it probably made the biggest splash because, like I said, this is like nothing we'd ever seen before. And certainly everybody, patients and providers alike, had been yearning for some kind of a maintenance that we could do. So we were super excited. But there was another trial that recently was published and came out. So the PRIMA trial was published actually this year, 2020. And one big difference from SOLO-1 is that this trial looked at all comers. So now this is looking not just at patients with BRCA mutations, but all patients with advanced ovarian cancer. And in fact, nearly half of the patients in this trial did not have any homologous recombination deficiency. So they had no mutation at all. And the other difference is that this looked at Niraparib instead of Olaparib. So essentially the same type of treatment randomization protocol. Half got Niraparib instead of 24 months. They got it for 36 months. And then they also, placebo, same thing, got 36 months of treatment. Still also similar profile, a little bit, patients with a little bit worse disease in this trial than in the SOLO-1, but still very, very similar statistics to what we see in real life. So here are the results. At a median follow-up of 13.8 months, basically Niraparib was found to improve the progression-free survival across all of the cohorts. So you can see here, the benefit was definitely the best in the BRCA patients. So BRCA positive patients had 22-month progression-free interval versus 10 months for people who got placebo. Patients who had HRD but not BRCA, similar results. So did almost as well as the patients with a BRCA mutation, 21 versus 10 months. Patients who had homologous recombinant deficient negative, so these are the people who have no mutation at all, had basically slightly less, pretty significantly less improvement. So it went from 5 months to 8 months. And then for all comers, when they lump everybody together, still this was statistically significant. So this was a big deal because the most statistically significant improvement certainly is in the BRCA positive or the HRD positive patients, but even in the HRD negative patients, there was some modest improvement that was considered statistically significant. So I put statistically significant in quotes. We don't have to get into this too much, but you know, all of these things have to be also considered a little bit balancing quality of life versus benefits, and we'll talk about that in a minute. So certainly I think this is arguably, there's no arguing here that this is an incredible improvement. This kind of modest improvement is a little bit more controversial about whether this is something that everybody should be doing. But just April of this year, the FDA approved niraparib for first-line maintenance for all comers. So anybody who completed platinum-based chemo and had at least a partial response. So this is a super duper huge deal in our field, and everybody's talking about it. So I'm excited to talk to you guys about it. The last trial I'll talk about is called the Paula trial. So Paula 1 is a little bit unique in the way that they tested PARP because they tested it in the frontline setting, but they tested it in combination with bevacizumab, also known as Avastin. Many of you probably have heard of it. But it's a VEGF inhibitor. So it basically attacks the blood vessels to the tumor. It's not a chemotherapy agent. It's also it's a monoclonal antibody basically that attacks the blood vessels. So in this trial, they also looked at all comers. In fact, the proportion of patients that had BRCA mutations and HRD mutations was very similar to the PRIMA trial we just talked about. So in this randomization, basically all the patients got chemotherapy with bevacizumab up front during their treatment. And then they were randomized to receive, everybody got the bevacizumab, and half the patients got Olaparib for 2 years, half the patients got placebo for 2 years. So it's a little bit confusing, but essentially they're asking the exact same question that we just talked about in Solo 1. The only difference is that everybody got the bevacizumab as well. And here are the results. So in short, again, you can see we see a very dramatic improvement in both progression-free survival in the BRCA positive patients and also in the HRD patients. And again, similar, it was all comers. So if you drop down to the all comers box, this is kind of interesting. All comers, still there's a benefit. But when you look in this trial at just the people who have no mutation, the HRD negative patients, there actually was not a difference. So that's different than the PRIMA trial a little bit. And then the all comers balances out because basically these people did way better and they are averaged with these people that didn't do better. And it kind of leads to kind of this middle of the ground result. But very recently, May of 2020, the FDA extended approval of Olaparib for the treatment of HRD positive patients when given with bevacizumab. So this is another treatment option that people are talking about. So again, kind of a little summary table, trying to highlight some of the main differences of the trials. It's a little bit of a busy slide, but the bottom line is basically that in all of the trials, the improvement in progression-free survival is striking in the BRCA positive patients and in the homologous recombination deficient patients. So people who have mutations in this pathway have a very striking response to PARP inhibitors. So back to our question, does PARP therapy help in the primary setting? I think safely we can say yes, it does help, especially in the right patient populations. So this data would really suggest that in patients who have BRCA or another HRD mutation, you should certainly be considered for a PARP inhibitor maintenance after they complete their primary therapy here. This is just a little summary slide of all, basically everything I just talked about, all these FDA approvals for PARP inhibitors. So how can they be used? Well, here's what we talked about. So after primary treatment, as a maintenance, you can use Olaparib for BRCA positive. You can use Olaparib with Avastin or bevacizumab in HRD positive patients. And then Niraparib is approved for all comers in this primary maintenance setting. After recurrence and response to platinum therapy, all three are approved: Olaparib, Rucaparib, and Niraparib. And then finally, as an actual monotherapy or treatment, Rucaparib can be used in BRCA positive patients at second recurrence, and then Olaparib and Niraparib can be used at third recurrence and beyond. So you can see there are many indications for PARP inhibitors, and this is really just the start. There's ongoing trials to look at how we can even broaden this group and look at them even more effectively. So now that we know all about how effective they are and how they work, let's talk about how they actually make patients feel, because obviously when choosing a therapy, this is critically important. PARP inhibitors are actually overall, I would say, tolerated quite well. So the most common side effects are nausea. You can see that all grades of nausea is pretty common, but severe nausea, what we call grade 3 nausea, is not super common, so about 5%. The second most common, I would say second most common side effect, or equally common side effect, is fatigue. So when we counsel patients, nausea and fatigue, by far the most common things we see with PARP inhibitors. And again, the incidence of severe fatigue is not high. It's actually pretty low. We do know that PARP inhibitors can suppress the bone marrow similarly to what chemotherapy can do. So it can cause anemia, drop the red cells. It can cause low platelets, especially Niraparib is notorious for dropping platelets. And it can also cause neutropenia or decrease white blood cell counts, putting people at risk for infection. I would say the majority of patients have some degree of this, but most of it is mild, and most of the time we can treat through that, either by holding the drug or by dose reducing. Sometimes we need to dose reduce. Probably the most severe, but thankfully very rare side effect of the PARP inhibitors is that they can cause a very rare type of syndrome called myelodysplastic syndrome or leukemia, AML. And you can see here the incidence, typically we quote less than 2%, so very unlikely, but if that does happen, it can be life-threatening. And if you see any person who's getting profound neutropenia, thrombocytopenia, anemia, any of these things that are not recovering, then that is something that needs to be considered and usually would warrant a referral to a hematologist, but thank God we almost never see that. So just some practical considerations when you're giving these drugs. And, honestly, we learned this kind of over time with now using this for several years, but, what's the best way to get people to be able to tolerate these effectively and feel well on them? In our practice, we typically ask people to start on some sort of acid blocker as kind of a preventative nausea measure when they start the PARP inhibitor. And we found that to be really effective. It actually helps people tolerate the drugs much better. We do ask people to eat it on an empty stomach. Typically, any time of day is fine. Olaparib and Rucaparib are twice-a-day drugs. Niraparib is a once-a-day drug. And it can be taken anytime, but eating it on a little bit of a full stomach helps people to not feel quite as sick. We have found that over time, the nausea and fatigue, actually, for that matter, typically gets better with being on it longer. So we try to tell people that when they start the first month, 6 weeks, you might feel a little blah, and it's typically not, you're not standing over the toilet throwing up. It's just kind of this underlying nausea that does typically get better. Same with the fatigue. People start out feeling kind of tired. Some of it's a little bit hard to tell because obviously they're also coming off of chemotherapy, so they're tired from that. So there's, kind of the recovery from chemo plus starting a medication that can also potentially cause fatigue. But we do see that typically when we're seeing people back 2-3 months after starting treatment, they're typically feeling much, much better. For all of these toxicities, as I mentioned, oftentimes you can take a treatment break. So if you have GI upset, problems with that, oftentimes you can do a week off and actually restart, sometimes even at the same dose. And sometimes people will feel fine for quite a while and not have to dose reduce. But we have dose reduced in other settings and had successful results. In fact, there is data that some of these drugs are equally effective at lower doses in some patients. In fact, with niraparib, there's some data to suggest that women, because of that platelet decrease that people see with it, that it's actually for people who are a low weight, so under 77 kilograms, or have a baseline platelet count of 150 or lower, that you should actually start at a lower dose to try to prevent the platelets from dropping. So there's a lot of tinkering that can be done with the dosing, with hopefully not a lot of efficacy compromise with the PARP inhibitors. And then we typically in our practice, and this is what's recommended, is that as you're going up on the dose, so for example, for Olaparib in our particular practice, we typically start at 150 milligrams twice a day. And we do that for 2 weeks. The full dose is 300 twice a day. We get labs weekly for 2 weeks. And then if at 2 weeks, everything's looking good with the labs, the patient's feeling well, we go up to the full dose of 300 twice a day. And we do then check labs for a full 4 weeks every week to be sure that the platelets are fine, the blood counts are fine, and that the kidney function, liver function look fine. So once we get to that point where they're fully ramped up on the full dose and they're tolerating it well, their labs have been stable, they will then get labs monthly during their treatments. And that's our kind of usual protocol. So, you know, we've had great success with this. I'd say the vast majority of my patients that are on these medications are feeling very well and enjoying really kind of quality time. So how do you decide if maintenance therapy is a good idea for you? Well, there are actually benefits and risks and disadvantages and benefits of both of these. And here are some of the kind of weighing of each side. So on one hand, the benefits, it may help the cancer from coming back. And if there is some growth, it may slow down that cancer growth. The disadvantages, it is that you're on a treatment. So, you know, you are still going to have some side effects. Whereas before, when we didn't do maintenance and we just did surveillance, you were completely off treatment. Cost is certainly an issue. We have had good success with getting these, you know, certainly paid for as by insurance, but they can be costly if people are having to pay out of pocket. It is more doctor's visits, so you are coming in to get labs. And then obviously there's limited information on the long-term side effects and benefits for each individual patient. We know about patient populations, but we don't know about each individual patient as well yet. But I'd say your doctor is really the best resource you have. They can really help you decide that in your specific case, you know, every person's cancer is different, every case is different. Your doctor will know the nuances of your particular cancer, and they will be able to help you decide whether a PARP inhibitor would be a good option for you. So I'd say in conclusion, if I had to kind of summarize all of this, the big points that we should take home: all patients that have ovarian cancer should undergo genetic testing. This is really important. It can actually impact treatment decisions and treatment options. And I'd say that this is actually a big paradigm shift. So from a kind of workflow perspective, this has really changed in my practice in the last several years because of the PARP inhibitor maintenance therapy option. It used to be that when I met patients with ovarian cancer, you know, they are just getting a diagnosis, they're often undergoing a big surgery, they're getting chemo, there's a lot of stress related. I always would talk to them about genetic testing because we know that it's part of what's NCCN guidelines for any epithelial ovarian cancer. And so I would always tell them, this is something we need to do. I'm going to put it on my list. Well, you know, when you're ready, we can do it now. I'd say a lot of patients felt very overwhelmed at first. And so many patients would decide to wait till they were done with their treatment. And I would always have it on my little to-do list so that it didn't fall off the radar. But I'd say that now I'm really making it clear that we do need to get the genetic testing during treatment. Unfortunately, it's really important because it's going to decide whether you would be a good candidate for the maintenance therapy. So it's really pushed the genetic testing to the forefront of our treatment discussions, and it has to be really done on the sooner side of our treatment. We do know PARP inhibitors have been found to increase the time to recurrence in certain patient populations, both after first-line treatment and in the recurrent setting. PARP inhibitors can be considered for actual monotherapy treatment in a select group of patients for second and third recurrence. And they do have some side effects, but most of the time these are manageable. And then balancing the risk benefits of using a PARP requires a thoughtful discussion with your doctor. So that's all I have. I hope it was useful. I hope I didn't bore you with too much science. I got nervous about that, but I feel like you guys are so educated, and, you know, my patients come to me with such good questions that kind of delving into the depths of it sometimes is good to kind of know what all the fuss is about. But you can see that there's a lot of fuss for good reason, because this is really, really cool and a lot of progress in our field. So.
Thank you so much, Dr. Moore. I do want to remind people they can use the chat to ask questions. So if people have questions, feel free to send that in there. I do see some people have also raised their hands. So you're welcome to either submit your question via chat or unmute to ask. But I feel like I interrupted you as you were introducing the team.
No, not at all. I was just I was going to quickly just mention our GYN Oncology team. So this is our division. We're very proud of it. Dr. Rodriguez is our boss, our division director, wonderful man, gifted surgeon, incredible, brilliant researcher with federal funding, just really one of my all-time idols. He's wonderful. This is me. And Tilly Vogel, another wonderful gem. We actually did our fellowship in the same place at UCLA. We did not overlap because I graduated before she was there, but we got such good reviews from people in LA about her that we had to hire her over with us. And we just love her. She's wonderful. Carolyn Kirshner was actually one of our initial partners when I first got here 7 years ago. She was a GYN oncologist. She's a marvelous woman. She's since retired from GYN Oncology, and she's heading up our survivorship program. I'm sure many of you have maybe met with her or know of her. She works very closely with the Cancer Wellness Center. She's a yoga teacher. She's incredible. And then Melissa Lippitt is our newest addition. She joined us this summer after finishing her fellowship at Johns Hopkins, and she's just super smart and super motivated, and we're really excited to have her. She'll be a great addition. So yeah, this is our team, and we're always happy to see patients. We were very passionate about what we do, or we love our job, and, you know, feel very blessed to get to do what we do every day. So I know I can speak for all of them. And then in terms of questions, I'm more than happy to answer. I'm not entirely sure how to do hand raising versus chat. So I don't know. Do you?
I do see a question that just came in on the chat. It was sent to me privately, so I will read it out loud. The person says, I do have a long question on genetic testing and have no genetic reason for getting ovarian. I was told you just got the short end of the stick. Just diagnosed 2 weeks ago and have a recurrence. We'll go down the road after I do chemo, then surgery, and then surgery or chemo. Would I fall in that category of all comers of what a PARP can and can't help?
It's a great question. I'm assuming that when you say you don't have, you've been told kind of you got the short end of the stick, typically that's actually talking specifically about that germline mutations we were talking about, like looking for ones that could have been passed down from your parents. That doesn't typically include that somatic testing of the tumor. And if you haven't had surgery yet, I don't know for sure, but my guess is that that somatic part of the genetic testing has not been performed yet. And oftentimes we do see that there can be a little bit of a lag time with that. Sometimes people get the germline testing first, and then once they have their surgery, if they do the surgery chemo, then once the tissue is basically available after surgery, that gets sent for the somatic testing. So if it's correct to your knowledge that your tumor has not been tested, then you still certainly could fall into one of the either HRD or BRCA groups that's that somatic version of the mutation in the tumor and not in the other. So I'm gonna try to go through the chat. Let's see. Oh, I'm doing a bad job with the chat. I'm really sorry.
So read the questions out as they see them come in.
Do you mind? That'd be great.
No, No problem at all. Another question that we received is, as a survivor of 4 years, is this something worth me looking into? I had the genetic testing and no mutations.
That's a really good question. Typically, so the maintenance therapy, the way that it's approved is really for starting it within 8 weeks of completing chemo. That's the way that the studies were designed. I've typically not advised people who have had very, very long progression-free intervals to suddenly start it as a maintenance at that point, because you've already probably fallen into that very good prognosis group. And in that point, I think that the side effects, even though there are not a ton, but there are some, would probably outweigh the benefits. So my guess is, in that situation, my guess would be it's probably not advisable to suddenly consider starting a PARP inhibitor now if you're still a survivor and disease-free.
What about, there's a question about, what about taking Olaparib, am I pronouncing that one correct? Longer than 2 years, just the person just completed 1 year and is doing well.
Yeah, so the Solo 1 trial, the interval of use was 24 months. And so right now, in our practice, we're typically following the guidelines to consider it, using it just for those 2 years. I am not, for the other trial we were talking about, the Prima trial, that was for 3 years for the Niraparib. I think most providers are trying to stick with the FDA indication and using that timeline, because people are doing already so well after those 2 years of use that it's a little bit hard without data to support it to know whether there's really a benefit to continuing it longer than the way that it was intended to be used.
Thank you. And the next question is, if a patient declines chemotherapy, would they be eligible to try a PARP inhibitor drug? And then there's a follow-up to that is, what are some of the future, is there a future for PARP inhibitors to be used in breast cancer treatment?
Yes, they are. They are being looked at in breast cancer for sure. And then if a patient declines chemo, could you be eligible for a PARP? The answer to that is there are ways you could be. It would typically, if you think back to the slides about how it can be used as a treatment, it's typically reserved for people who do have a BRCA mutation or an HRD deficiency after certain rounds of chemo. So it's not something, unfortunately, it's hard to get these approved to be used outside of the way that they're indicated. So if it were like a first recurrence, typically we can't just jump to doing a PARP inhibitor for treatment. Now, similarly, as a maintenance, the way that it's approved is after platinum chemo. So typically you can't just jump to the PARP without the chemo. Now, I have had some patients, just to throw it out there for all considerations, who've been very hesitant about chemo. Let's say we would consider repeating treatment with carboplatin and Taxol, which would be one of our standard recurrence regimens, where we've done just the carboplatin alone, which is a lot less toxic. And I've even had some people who've done it, instead of the 6 cycles, let's say they did 4 and decided they didn't want to do the others. So the real way that you can actually get it is by doing some amount of chemo, but there are ways of kind of getting around doing our standard chemo and still being eligible for use in that situation.
The next question, the person notes that they have stage 4 ovarian cancer after chemo on Avastin for the 3rd try, no surgery yet for 15 months. Should the person add PARP inhibitors to the Avastin now?
That's a great question. I've had people actually come to see me for opinions about that. And excuse me. So there is data, obviously, for use with the Avastin and the PARP together, not specifically on in your situation. It's after the first line setting, so it would be kind of extrapolating. I typically, in my own practice, think that the better way of using it is, so if the Avastin if let's say you're in remission or you have stable disease on the Avastin and the Avastin's doing what it should to kind of keep things stable, I typically like to keep the PARP inhibitor for use at a later time. So, with recurrent ovarian cancer, thankfully we have many treatment options that range from, chemos to targeted therapies to other things, but they're not endless, right? They're not endless options. And so I tend to not like to layer too many on top of one another, because if you use it now, if the Avastin's already doing a pretty good job of keeping things at bay, then you've kind of used up the PARP option, whereas you could save the PARP and basically use it later if the Avastin stopped working. So, obviously I'd need to look at your entire chart to give you a formal opinion, but that's in my practice. I've oftentimes separated them out so that they can be used sequentially and hopefully have a longer duration of overall effect, essentially.
Thank you so much. One of the other questions is regarding insurance and genetic testing. Is that something that you help the patients get covered?
Yes. So any patient with epithelial ovarian cancer should be covered for genetic testing per NCCN guidelines. Another plug for our genetics division. They are phenomenal. They will always, when they see patients, look at their insurance and quote them basically what the maximum amount would be that they could possibly be charged with their insurance for any of the tests that they're recommending. So you'll never just get a bill that you're not expecting. They will always go through that with you before ordering anything or sending it off. So that's very helpful.
And that's sort of a good segue, as someone commented earlier that the genetic team at North Shore is great. So thank you for sharing.
I saw that. I agree completely. They're wonderful.
The person is noting, thank you for hitting on the quality of life issue and cost issue, because now with the recurrence, they are evaluating all before they go into another surgery, or whether they do 3 rounds of chemo and then scan to see if tumors are shrinking.
Yeah, and that's one of the things. It's, I think with all of our cancer treatments, it's super critically important, whether we're talking about surgery, chemo, PARPs, we've got to be thinking about quality of life, because obviously our goal with all of this is to extend people's lives, but we need to extend it in a way that's meaningful and that people have a reasonable quality of life. So I will say, kind of as a general feeling about the PARP inhibitors, is that when used in the right population, I think that the quality of life aspect is maintained really quite well, and that the degree of benefit that people get is definitely overpowers any small amount of toxicity that people get.
Thank you for clarifying that. I don't have any more questions coming in through the chat. I just want to check in with everyone. Are there any other questions for tonight? Feel free to unmute yourself as well if you would like to ask those questions that way. And I'll give just another minute if someone's typing. While everyone is thinking about questions or typing, I want to note that following the program, I will be sending out a program evaluation. It's just a simple Google form. We will not be collecting any information, so it's absolutely confidential. Feel free to give us your feedback and include any other topics in there that you would like to see in the future. We love partnering with North Shore and bringing various different speakers to help answer questions you may have.
Thank you very much. It was great.
Oh, thank you. Thanks so much for having me. I'm so impressed that everybody logged in at this